Good day. Bioethics is a subfield of ethics that explain ethical questions related to the life sciences, specifically helping people make decisions about their behavior and about policy questions that governments, organizations, communities, and individuals may face when they consider how best to use new biomedical knowledge, technology, innovations, and research. Today, bioethics help address decision-making that attend to problems arising from healthcare issues as well as research. The following contents of our report include bioethics definition, principles, experiences from interviews, and cases. First up, what is bioethics? Bioethics, also known as healthcare ethics or medical ethics, at its simplest definition is a set of moral principles, beliefs, and values that guide us in making choices about medical care. Bioethics comes from the Greek words bios, which means life, and ethos, which means custom or ethics. It was coined in 1927 by Fritz Jaher, and Daniel Callahan was the first to introduce the term bioethics in 1969, and later, Van Rensselaer-Potter or Dr. Potter popularized the term in 1970. On the one hand, as we know, ethics is a branch of philosophy that studies human acts and provides norms for their goodness and badness, or in layman's terms, studies the rightness or wrongness of human actions. On the other hand, bioethics is the application of the principles of ethics to the field of medicine and healthcare. It involves the concerns of human beings and their close relationship with other organisms. Bioethics is also the ethics of biology, which may be subdivided into environment, animal, and medical ethics. It has a distinct way of dealing with the interrelationships of human beings with the environment and nature. At the core of healthcare ethics or bioethics is our sense of right and wrong and our beliefs about rights we possess and duties we owe others. Thinking carefully about the ethical aspects of healthcare decisions helps us make choices that are right, good, fair, and just. Now, broadly construed, bioethics as an applied ethics is defined as the ethics of life. As an applied ethics, its main and most relevant issues are those relating to life, health, and death that have been brought about by modern biological technology, especially how they have impacted human values. These bioethical issues and concerns will be discussed by Mr. Fernandez.
Thank you for that, Mark Neil. Now let's have bioethics issues and concerns. Bioethics is concerned about the determination of the rightness or wrongness of the discoveries and developments in medical science and the incorporation of human rights and values to health and life. The following topics are the most common scientific topics and advancements that seem to have gotten the attention of bioethics supporters and the general public. First, let's have abortion. It refers to the intentional premature ending of a pregnancy. It could be taken by force through surgery or taking medications. The topic of abortion raises personal issues about many topics such as morals, religion, autonomy, and science and medicine. Although abortion has long been debated in bioethics, there is still no moral consensus achieved. Next is artificial insemination or surrogacy. It refers to the process of assisting the reproduction of parents who are incapable of doing so. The bioethical concern here is the confusion in the identity of the child, whether or not his biological parents are considered his true parents. Another is contraception. It is the deliberate use of artificial methods or other techniques to prevent pregnancy as a consequence of sexual intercourse, Although it has positive purposes, its underlying bioethical issue is that it makes immoral behavior less risky by making it more likely that people will have safe sex outside marriage. Next is cryonics. It refers to the scientific method of freezing a newly dead individual to reanimate or bring him to life later on, believing that this process could reverse the process of death and defies the natural cycle of life. Several bioethical issues were raised against it, such as immortality, and supporters of bioethics believe that this idea should not prevail given that the planet is already under the crisis of unsustainable population and limited resources. And next is euthanasia, literally means good death. Euthanasia is the process of intending to end the life of an individual to stop one's pain and suffering. Its underlying bioethical issue is that euthanasia challenges the belief that is concerned with the sanctity and equality of all life forms. Euthanasia corrupts the practice of medicine as well as the value of suicide prevention. And lastly, organ donation. Despite having a good intention, the practice of donating or receiving an organ seems to give rise to ethical issues because there is a big demand for organ transplants. And along with this demand is fear for illegal organ stealing from the living without their consent to create organ farms to sell organs for huge prices. Take human trafficking for example. Those are the major issues that bioethics is facing. Some of us may be in favor for some, but in light of the very definition of bioethics, which is to determine the rightness and wrongness of those developments, it will remain unaccepted or questionable due to the ethical standards of this discipline. And here's Kenji to tell you about the principles of bioethics.
Now let's discuss the four main principles of bioethics: beneficence, non-maleficence, autonomy, and justice. Beneficence is the obligation of a physician to act for the benefit of the patient and supports a number of moral rules to protect and defend the rights of others, prevent harm, remove conditions that will cause harm, help persons with disabilities, and rescue persons in danger. In other words, it requires that the procedure be provided with the intent of doing good for the patients involved. Demands that healthcare providers develop and maintain skills and knowledge, continually update training, consider individual circumstances of all patients, and strive for net benefit. The next principle is non-maleficence. Now, non-maleficence is basically the obligation of a physician not to harm the patient. It requires that a procedure does not harm the patient involved or others in the society. One example of applying this principle is through infertility specialists. They operate under the assumption that they are doing no harm or at least minimizing harm by pursuing the greater good. However, because assistive reproductive technologies have limited success rates on certain overall outcomes, the emotional state of the patient may be impacted negatively. In some cases, it is difficult for doctors to successfully apply the do no harm principle.
Autonomy requires that the patient have autonomy of thought, intention, and action when making decisions regarding healthcare procedures. The philosophical basis for autonomy, as understood by Immanuel Kant and John Stuart Mill and accepted as an ethical principle, is that all people have intrinsic and unconditional worth and as a result should have the ability to make moral decisions and decisions that are consistent with those values, as well as the right to exercise their capacity for self-determination. With a concise remark, every human being of adult years and sound mind has a right to select what shall be done with his own body. Justice Cardozo recognized this ethical principle in a court case 1914. People who lack the ability to act independently, such as newborn children and those who are incompetent due to a mental or physical illness, are not covered by the principle of autonomy. A strict distinction between incompetence to make decisions about one's health care, assessed by medical professionals, and incompetence determined by law is not useful, though, as a clinician assessment of a patient's lack of decision-making capacity based on a physical or mental disorder has the same practical implication as a legal determination of incompetence. In order for the patient to exercise self-determination, the doctor must provide all relevant medical information and treatment options. This respect for the principles of autonomy also encourages informed consent, truth-telling, and confidentiality. The requirements of an informed consent for a medical or surgical procedure or for research are that the patient or subject must be competent to understand and decide, receives a full disclosure, comprehends the disclosure, acts voluntarily, and consents to the proposed action. Truth-telling is a vital component in a physician-patient relationship. Without this component, the physician loses the trust of the patient. An autonomous patient has not only the right to know of his or her diagnosis and prognosis, but also has the option to forgo this disclosure. Confidentiality. Physicians are prohibited from sharing a patient's protected health information with a third party without the patient's consent. The sharing of medical information required for the patient's care from the primary doctor to consultants and other healthcare teams constitutes a clear exemption with implicit patient authorization. Justice is generally interpreted as fair, equitable, and appropriate treatment of persons. Of the several categories of justice, the one that is most pertinent to clinical ethics is distributive justice. Distributive justice refers to the fair, equitable, and appropriate distribution of healthcare resources determined by justified norms that structures the terms of social cooperation. In situations where there are conflicts of interests, the patient's fairness comes first. When a certain course of treatment is chosen over alternatives, or a costly medication is chosen over a similarly effective but less costly one because it benefits the doctor financially or otherwise, this concept is obviously violated.
An interview was conducted by Cindy Liu, which was then published and entitled as Bioethics in Science and Medicine, an interview with Professor David Magnus. Just a quick background information about Professor David. He got his PhD or Doctor of Philosophy in Stanford University, where he also teaches there as a Professor of Medicine and Biomedical Ethics, as well as a Professor of Pediatrics. He also directs the Stanford Center for Biomedical Ethics, and for over 70 academic bioethics programs across North America, he represented the Association of Bioethics Program Directors as the former president. Currently, he co-chairs the Stanford Healthcare Ethics Committee, which provides consultation to doctors, patients, and families on a wide range of ethical issues that arise in clinical care. Let us now dive into the first question that was being asked with regard to his duty as a director of the Stanford Center for Biomedical Ethics in terms of the kind of work the center does and how does the center collaborate with researchers as well as administration. Professor David provided 3 different things they do as a mission in the center. First one is research. According to him, they spent a lot of time on research ethics. When non-invasive prenatal testing first came online, they spent a lot of time developing articles and approaches and guidelines. They published some guidance for clinicians, the people who develop the science, and for consumers. Second is what he called service. They provide clinical ethics consultation in both the adult and pediatric hospitals in their local. They also provide research consult ethics service, which they consult to either researcher or the institutional review board itself on different topics. And lastly is their engagement in a lot of policy level issues where they help give guidance on some policy issues and sometimes they help in writing some of their hospital policies. The third and the most exciting synergy that they do is teaching. They teach undergraduates at every level. They also have faculty centered in the law school who also teach law school classes, and they do education for postdocs, residents, and their fellows professor. In terms of collaborating with researchers and administration, if they find a research interesting or some ethical issues from the research they have consulted by doing their service, they will then start trying to do research projects and will often bring medical students or even undergraduates as the first authors in publishing the articles out of it. So those are the things that they do in the center.
The second question pertains to the undergraduates who wanted to learn and work about bioethics research. So the question goes like this. There are many opportunities for undergraduates to become involved in scientific or computational research, but it can be more challenging to learn about and work on bioethics research. How can undergraduates get involved with bioethics research at Stanford? Magnus find this interesting. So to answer the question, undergraduates can also take part or get involved in bioethics research by doing this too. First is to apply as research assistant when they post jobs or positions. Second is that when students are working with their thesis or their research projects, they can also work with Stanford. For David Magnus and his team had met several students who are working on different research projects, so they have the mastery in this kind of field. David also shared that he himself supervised one or two undergraduate theses. He also mentioned about that bioethics is an emphasis in human biology, and ethics in society is an honors major as well. On the other hand, they have also hired undergraduates on grants to work with them on research projects or to be involved in different things. And that is a great advantage for students who are planning to apply to medical schools and even publish articles. The last question. For students looking to work in bioethics after undergraduate or after college, are there any graduate programs or opportunities that you recommend? Bioethics is not a discipline, it is an interdisciplinary field. This is the highlight of the answer of Dr. David. This means that the pathways are significantly more difficult, and to be quite honest, they are even more difficult when compared to some other interdisciplinary subjects. For example, in public health, they have their own programs that are well established, while in bioethics, it is not as evident where to turn for bioethics. Honestly speaking, there are obstacles to understand how you feel in the fields that are genuinely pretty important. There are PhD programs in bioethics, but there are very small numbers of them. And frankly, it's not clear that those are the best ways to get into the field of bioethics. Despite all of this, David said that the biggest growth areas are in medicine, like physicians becoming bioethicists and social scientists becoming bioethicists, whereas philosophy and to some extent theology or religious studies have been the more traditional disciplines, just like him. He did clinical ethics. He is also philosopher by training. So when we add up his degrees or studies, it's 2 philosophers, 2 anthropologists, 4 or 5 physicians, and a couple of lawyers.
As for the related case studies, we actually prepared 6 distinct cases, but since there's only a limited time for our presentation, we will only be discussing 2 to 3 cases in all. Case number 1 talks about the issue of the principle over beneficence and principle of autonomy being in conflict, while case number 2 is about autonomy prevailing over beneficence, and the last case regards to clinically non-beneficial interventions. Case number 1 is about a 20-year-old student living in the college hostel being brought by a friend to the emergency department because of unrelenting headache and a fever of 40 degrees Celsius. He appeared drowsy but was responsive, and neck rigidity on examination. Lumbar puncture was done and spinal fluid appeared cloudy and showed increased white cells. Gram stain showed gram-positive diplococci. Based on the diagnosis of bacterial meningitis, appropriate antibiotics were begun and hospitalization was instituted. Although initial consent for diagnosis was implicit and consent for lumbar puncture was explicit, the patient refuses treatment without giving any reason and insists to return to his hostel, even after explanation by the physician as to the seriousness of his diagnosis and the absolute need for prompt treatment. The patient is adamant in his refusal. In this case, the principle of beneficence and principle of autonomy are in conflict. The weighing of factors: first, patient may not be making a reasoned decision in his best interest because of temporary mental incapacity, and second, the severity of life-threatening illness and the urgency to treat to save his life supports the decision in favor of beneficence.
Thank you, Lina. Now here are more cases in regards to bioethics. Southern Indian widow, 67, lives in Wisconsin with her son and family. For months she was nauseous and lost weight. She had dark urine and yellow skin the past week. Her son brought her to a multi-specialty teaching hospital and told the doctor that his mother had jaundice and not to tell her about any life-threatening diseases. Since she is older and frail, he requested all information and that cancer be left untreated. She has pancreatic cancer, which chemotherapy could help in possibly curing her or prolong her life. In some ancient cultures, family members, especially senior men, make marriage, job, and healthcare decisions for others. Given this cultural perspective, the son can make healthcare decisions for his mother. Thus, the doctor must perform multiple tasks that may conflict. To respect cultural values, directly learn the patient's preferences, comply with the American norm of full disclosure to the patient, and refuse the son's demands. So, the patient can delegate decision-making to another person under autonomy. Thus, it is best to gently inform the patient, with a translator if necessary, that the disease requires treatment decisions. The doctor should ask if she would rather make these decisions herself or give her son all the information and let him decide. So, moving on to another case of bioethics. For abdominal pain and multiple gallstones, a 45-year-old woman had laparotomy and cholecystectomy. She returned with fever, abdominal pain, and tenderness 3 weeks after hospital treatment. As her fever persisted, laparotomy and exploration revealed a sponge from her recent cholecystectomy. It was removed, cleansed, and incision closed. She recovered and was discharged on antibiotics. Should the surgeon inform the patient of his error? In this case, the patient's autonomy requires truth-telling. The error hurt the patient, morbidity, readmission, a second surgery, and monetary loss. The surgeon must inform the patient of the error and apologize, even though the result fixed the problem. Most U.S. hospitals have risk reduction mechanisms that would investigate the incident and make recommendations to mitigate and prevent errors. To avoid liability litigation, many institutions waive fees and hospital charges or pay patients. If no such mechanism exists, notify the hospital. The hospital should apologize and compensate the patient. This situation could lead to a malpractice suit in the US or elsewhere, but most patients trust their doctors and are not vindictive.